I really enjoy the opportunity to talk about flat foot. It is something that I've really spent a lot of time on recently, the past few years. And what's interesting is how much I've changed in the way I approach my thought process on evaluating this, and my techniques at reconstructing it have changed dramatically as a result of some new research, some of which Mark already touched on, a better understanding of the medial anatomy of the hindfoot, and then some techniques that have really just created tremendous confidence in not just rebuilding valgus stability, but even preserving talonavicular joints far more commonly than I used to in these more severe flat foot cases. And so I would argue now that my primary focus is the medial ligaments, and everything else I do is to augment, to protect that. And that's not really how I thought of it before. And I think the world in general has tended to think of this as a process where we worked around the spring ligament. We didn't necessarily address it directly. And I feel, and a lot of us feel, the trend has switched to now focusing more on those ligaments. So I want to quickly talk about the science that's led me to this change and many others to this change. We'll go through my technique specifically, and I'll show quite a bit of that. And then we'll go over a couple of cases at the end. Again, I do some consultant work for Artelon, just as Dr. Burlett had mentioned, and did a great review on what Artelon is. It is one particular graft that you could use for such reconstructions. It's certainly not the only one, and we'll talk about graft choice. It certainly is surgeon dependent, but this one is very appealing for this reconstruction in many cases. I think a good place to start is a consensus group of flat foot reconstruction experts met recently and produced quite a few articles on flat foot, which was published in Foot and Ankle International last year, and a few pertinent points to the medial soft tissues that I want to bring up. And that is that the focus is turning away from the posterior tibial tendon as the source of the problem. In numerous biomechanical studies, when you release the posterior tibial tendon, you can't quite create that predictable flat foot deformity. It seems to be more a result of the deformity to see the posterior tibial tendon disease. The relevance of the tibiocalcaneal navicular ligament, which I'm going to refer to as the tibio spring, has traditionally been neglected in most of our classification and descriptive systems and the algorithms that we use to diagnose and treat this. And that certainly needs to change, as we feel that those tissues are a huge component of the problem. Again, like I said earlier, release of that tibio spring predictably leads to a progressive flat foot deformity in biomechanical models. And also, release of the tibio spring leads to ankle valgus. So just like Dr. Preisel mentioned, these fibers play a critical role in all of the hindfoot joints around the talus, not just the subtalar and the talonavicular, it's the ankle just as much. So the anatomy, this is probably where things have changed the most. And this is another study, just like the one that Dr. Preisel was mentioning, done in 2014, Campbell, where they look at the deltoid ligament in multiple cadavers, and they find something that we've all appreciated. It's widely variable. And so, what is the consistent part of this? The tibio spring. Okay, well, what's the tibio spring? It's not just like we used to think of it, where there was a superficial deltoid here and a deep deltoid there and a spring ligament down here. That's not necessarily present in everyone. And our ability to restore hindfoot valgus stability, to restore that stability with your reconstruction of these independent ligaments hasn't turned out so well. So what are we seeing in these cadavers that is consistent? We're seeing this structure is consistent. It typically compromises almost 50% of the overall ligaments in the area, and it's there in just about every single case. And as reconstruction techniques have focused on rebuilding this particular ligament, all of a sudden our ability to restore hindfoot valgus has increased dramatically. And some of this started, John DeLand and his group up in New York have done a tremendous amount of excellent work in this area. And this was a study they did back in 2005, where you could really see the gears turning. They're seeing all kinds of spring ligament and deltoid ligament degeneration in their flat foot reconstructions. And they said, well, hey, how often is this actually there? And they did MRIs on flat foots, and they compared it against controls. And not only was the spring ligament just as commonly injured or diseased as the posterior tibial tendon, but to the same severity. And I don't think that came as a surprise to them, because that tissue is pretty much always damaged when you're dealing with a progressive flat foot deformity. They've taken this quite a bit further, them and others, comparing various reconstruction techniques. And this one in 2015 was a bit of a surprise, and they openly admitted it. They were comparing a traditional spring ligament reconstruction, listed under letter A there, against the talonavicular reconstruction and the tibionavicular band of the tibio spring. And interestingly, it performed the worst in a flat foot model that they were testing in their biomechanics lab. And what performed the best was this, by far. In some cases, 400% better at restoring subtalar valgus stability, as well as the ankle valgus and talonavicular joint eversion. So it was Grunfeld shortly thereafter that started incorporating this into his flat foot reconstructions, doing a tibio spring, two-limbed graft, allograft, from the medial malleolus down to the sustentaculum and down to the navicular, and having great results there. This was then put to the test in the biomechanics lab and found that when you release that particular band, you can create valgus instability, and not just the subtalar joint and not just through the talonavicular joint, but the ankle as well. And that reconstructing those particular limbs was able to restore it far better than any other technique we've been using so far. So the lights are starting to go off that maybe we've just been off a little bit in the way we were addressing this. We were on the right track. We were just not appreciating the significance of the deltoid and spring combination. So John Deland, once again, and his group in New York started using this technique in their flat foot reconstructions and having very promising early results. That technique is now being compared on the bench against a traditional deltoid reconstruction and a traditional spring. And to no one's surprise, we find that the tibio spring reconstruction is far more powerful at restoring hindfoot valgus stability than any individual ligament technique that we've used in the past. So the overarching theme here is that we shouldn't be thinking of the deltoid and the spring as individual ligaments, just as Dr. Preisel had mentioned earlier. With regard to flat foot, it is one giant confluence of ligaments. And so I would anticipate in the future that the terminology of these ligaments, especially with flat foot, will likely change to be sure that we aren't inadvertently creating a situation where we neglect parts of this. So what are some basic thoughts after the research here? Well, final thoughts are that in general, you should be trying to preserve talonavicular joints by rebuilding the medial soft tissues. The periarticular osteotomies and other procedures we do with a progressive flat foot deformity are done to protect those medial soft tissues. The tibio spring component of the medial soft tissues is the critical component of the progressive flat foot deformity, and one that we should focus our reconstructions on. And even when you're using hindfoot arthrodesis, subtalar joint, or even talonavicular joint as a component of your severe flat foot deformity correction, reconstruction of these ligaments should be strongly considered to prevent that dreaded ankle valgus, just like Dr. Preisel had showed in his presentation. So technique tips. When I'm doing this procedure, pretty much every time I'm doing an isolated gastrocnemius recession, it's almost always tight. I'm doing a medial displacement calcaneus osteotomy. I found that I'm shifting more towards a single screw rather than double screws, only because there's quite a bit that has to go on in that calcaneus, and I need the real estate. There's lateral column lengthening, which I wasn't using as much in the beginning because I was so impressed with the amount of correction I could get with my soft tissue repair. But I'm adding it more lately only because I feel that by adding that lateral column, I am protecting my repair better than I was before. I tend to go rather small in my lateral column lengthening. Max might be an 8mm wedge. My medial approach, pretty traditional. It's gotten a touch more plantar over the years to make sure I have good access to the sustentaculum as well as the plantar navicular. So something to keep in mind. When you first get into this case, the spring ligament tear is going to be there and going to be evident. I would encourage you to find it immediately because it tends to be forgotten as you get wrapped up in all the steps of the case. You get to the end, you've got grafts placed, and now you can't put the sutures into your spring ligament. So I will repair them. In this particular case, it's a large chronic spring ligament tear, and there's no way I'm going to be able to pull those together, even with the foot in a reduced position. So I'm going to use the stump of my posterior tibial tendon there in the clamp to help fill that hole at the end of the case. And there's the final repair. This is another technique here where the ligaments are torn off the navicular. So we placed a grasping suture around that ligament, and that suture will then get incorporated into my navicular tunnel along with the FDL transfer to help reduce that down at the end of the case. So just remember, think of the tear early, think of a strategy to repair it, place your sutures, and tie them at the conclusion of the case. I think another thing about this case that might discourage certain surgeons from taking it on is that sustentaculum tunnel. It can be technically demanding and a little bit intimidating at first, It really isn't. It's anatomy that we're all familiar with. Once you've harvested the FDL, the floor of that tendon sheath, your substentaculum is right underneath it. Usually it's the superior margin of that groove is where your substentaculum is. And just aim your guide wire inferior, posterior away from the subtalar joint. I get a nice shot down the wire to make sure that I'm within the confines of the substentaculum. But probably the most important view is that Harris view here. And as long as you're in the center of that substentaculum on multiple flexion views, you're good to go. I'm aiming towards the perineal tubercle on the opposite side. Something else to keep in mind is that it's really hard bone. And you're going to see a little smoke come up right here from the drill, right? You take your time when you drill this. I think if we're in a hurry, you can create thermal necrosis there, which will weaken your fixation point and possibly lead to failure. So take your time drilling that, use good technique, and I don't think you'll have issues there. With regards to graft, you need a long graft for this technique, something that's at least 23 centimeters long. So from an allograft standpoint, I like to use a perineal longus, but with something such as a synthetic like this Artelon, it's 32 centimeters long. It's more than adequate. There are other grafts described in the literature, including autograft. All work very well so far in the literature. I'll use my short limb. That'll be about 70 millimeters long in this case, and I'm going to put 25 millimeters of that up into my medial malleolus here with an interference screw. I then take my FDL and my long limb and place them from plantar to dorsal through the navicular and fix that with a second screw. I then take the long limb from the top of the navicular and my short limb from the medial malleolus and take them to the sustentaculum. And you can see the assistant tensioning those on the far side. And of course, that's the time to be fixing your spring ligament or tying those spring ligament sutures. When you're getting ready for your final reduction here and tensioning of these ligaments, tie those sutures that you placed earlier. And you can see those limbs going there into the sustentaculum and then the final reconstruction there. This is the original patient that I showed you earlier in the presentation. So a couple of cases quickly. And I like these cases because they show how much I've changed in my approach to these types of patients. This is a 66-year-old female with a significant progressive flat foot deformity. And here's her ankle, by the way. You know, and traditionally I looked at this and I would say, okay, for me that's a medial double arthrodesis with some soft tissue repair, but she was flexible. I could easily reduce this deformity.